So good afternoon, everybody. Today I'm going to present an interesting case, and today's case is a 23 years old male presenting with progressive weakness in both of his leg for 2 years, and
Before we move on to the illness, let's everybody in the rooms ask for further history of this patient. If you are a doctor at the OPD and you met this patient who present with progressive weakness in both legs for 2 years, which symptoms or which question you would like to ask the patient for further differential diagnosis or for diagnosis of the symptoms of the patient? Maybe start with first year resident.
First year resident Panmasorn. I will ask, did he have numbness or fever?
okay, he had numbness in both of his foot or both of his feet, but it's only occasionally. He denied any fever.
And other symptom like back pain.
He didn't have any back pain.
Did he have any trauma before?
He had a trauma before, but it wasn't at his back. It was at his left knee. So for back trauma, he didn't have any trauma.
Second year or third year resident? Second year resident.
Can he has control to void and control to who?
Okay. So he later on he had like a trouble with with urinary incontinence and even bowel incontinence as well.
So when assessed with a patient who present with weakness, you have to identify or clarify that if the weakness is like on where is the lesion, like usually you should ask for the associated symptoms like numbness or pain or any characteristic of the pain if the patient has pain. But in this patient, he didn't have any pain, so we only have to ask the weakness and also for more detail like where is the level of weakness and also the numbness, because the patient declared that he has occasional numbness in both feet, but the weakness he said that is progress in the both legs, and also the onset that the presenter has already presented is like usually like chronic onset because it's happened like 2 years ago. Associated trauma should be the question should be asked, and also the like the maybe there are other underlying disease or other any associated injuries should be asked in this patient. So let's move on to the present illness.
So the present illness, 2 years before visiting the hospital, he said that he had been experienced like difficulties in running because he had trouble balancing himself, and he also complained of occasional numbness in both of his feet. And two months before visiting the clinic, he said that walking became more difficult because he was unable to fully perform dorsiflexions in his left ankle, and he said that the weakness, he felt weakness in both of his lower leg. He said that it was like from knee and below, and he still complained of frequent numbness along the side of both of his feet. And 2 days before visiting the clinic, now the weakness become worse, and he was not able to walk, and even he was not able to hold his bowel or bladder. And he said that now his weakness like move upward to both of his hip and down below, and he denied any back pain, weight loss, fever, or weakness elsewhere.
So is there any information you would like to know more after knowing the patient the present illness? Any history you would like to ask?
Did she have fever?
No,
Mm.
no. He didn't have any fever.
So has the patient been treated any hospital or clinic before coming to our hospital?
He
No.
denied any like recent illness or hospitalization.
So it's quite strange that the onset like 2 years ago and worsening in 2 months and gradually like rapid worsen in 2 days, but the patient hadn't been seeking any medical care before. Okay. So let's move on to the next part.
So for the past history, he denied any underlying disease, and he denied any past illness or hospitalizations. And for his past trauma history, he had a left ACL injury, but he didn't get any surgery. It was only conservative treatment for 9 years. And because of his left ACL injury, he thought that his weakness was from the ACL injury. So he didn't seek any medication or doctors. And he denied use of any current medications and herbal medication as well. And he denied any allergy. He's from Bangkok, but he's currently in Sriracha, Chonburi, and he's just graduated. He denied any use of alcohol, smoking, or recreational drugs. And in family history, he denied any disease or illness, including cancers and any other diseases in family members. So next is the physical examinations. So the vital signs and general appearance, heart and lungs are unremarkable, so they're pretty normal, and that including abdomen and extremities. For extremities, there were no edema or any skin lesions. Uh, for near for the neurological examinations, so the patient was oriented to place, time, and person, and the cranial nerve all were intact. So there was not any problem in the cranial nerve. But the positive finding that was found was his motor power was decreased. So almost all the motor power in his lower extremity decreased to grade 4. It's from his L2 to L4, 5, and S1. The only knee extensions was intact. He also reported a decrease in pinprick sensations below T4 levels, but his pain and temperature sensations was still intact.
Anyone wants to discuss after this physical examination show here? Apart from the physical examination, do you think you could localize where the lesion is from this physical examination, or do you need more neurological exam for this patient? Or maybe if you don't have any idea, like you can just like recall back to the upper motor neuron or lower motor neuron lesion. So from the physical exam, do you think it's upper or it's lower? And what is the reason that you think it's upper or you think it's lower?
I think it is the upper motor neuron lesion because the patient have abnormal in Babinski sign and hyperreflexia.
Mm-hmm. And any other reason? So you mentioned the upper motor neuron lesion, and what should be the where is the upper motor neuron lesion, like in the brain or in any part? Upper is like very broad differential diagnosis.
Maybe spinal cord lesion.
Mhm.
I think.
And from the physical exam, can you identify which part of the spinal cord, like posterior, lateral, or central? Or the presenter, do you want to provide any information for this patient? Yeah. Oh, that's
uh, mean the localization, right? So the the reflex that the patients also experience, there was also hyperreflexia in his patella and Achilles tendon, and Babinski sign was dorsiflexions, but his cerebellar sign was normal, and digital rectal examination found good sphincter tone. And for the localization of the spinal cord, we actually talk about it after this, about that tract, the spinal tract. But if it's weakness, like voluntary weakness, is usually the lateral cortical spinal tract, and if it's the sensations, the pinprick sensations, it's usually the posterior column, which I will be talking about it later on. So what
physical exam is that at the outpatient department, you cannot just send the MRI right away. So the physical exam, like complete motor, sensory, reflex, and also some special signs that the patient can localize where the lesion is, because we cannot send the MRI right away or send the MRI whole spinal cord and also the brain. So the history and physical exam is very important in this patient. So let's move on to the next part. Yeah.
So what are the problem lists in this patient?
Second year resident. Sorry, first year first.
Maybe 25 years old man present with progressive paraplegia both side for 2 years and maybe the upper motor neuron lesion from physical examination
Another one.
with cauda equina because he can't control the bowel bladder no bowel bladder control as
With
well.
cauda equina. So you
แบบ
think the lesion is at
ออก
the
ว่า ต้องยังไงนะ แบบว่าพอร์ตคอมเพรสเอ๊ะไม่ใช่เปล่าthe lesion involve L5 and
Lesion involve L5 to S1
S1
associated to cauda equina.
is longitudinal from L5 to S1 or above L5 or the whole. You think
not
it's
not
the
sure
sensory level, is it important? The sensory to the part physical examination, he shows that the decreased sensation below T4.
อ๋อบัตรมอเตอร์เป็น skip lesion เหรองงอะอาจารย์ I think the lesion maybe is above L2 but in the decreased twin peak sensation below T4 lesion may be around under T2 to above L2 but not sure like is a generalized lesions or skip lesion not sure ค่ะ
So The problem is a 23 years old male presented with progressive bilateral leg weakness for 2 years, which he also had a deficit in the sensory level at T4 levels. It was the decrease in pinprick sensations before the T4 levels, and he also had hyperreflexia below L3 spinal levels, and he had bladder and bowel dysfunctions consistent with urge incontinence. So I will be talking about the approach in this patient. So for the approach, we could approach based on the pattern of the motor power loss. In this patient, the patient has like paraplegia, which is either motor loss in both of his arm or legs, which will point out to the etiology of like the lesion in the spinal cord or in the peripheral nerve. Other includes like hemiplegia, quadriplegia, ascending, descending, and diffuse pattern. Actually, this patient had like some kind of ascending pattern as well, because at first his weakness was only at his ankle, then it progressed up to his hip. So we could say that the patient could like the etiology could be like Guillain-Barré syndrome or transverse myelitis as well. So apart from when we can define the pattern of the weakness, in this case is paraplegia, we could also localize based on like the upper motor neurons and the lower motor neurons. So the parameter that we use to separate between these two are like the inspection tone power reflexes and plantar reflex. And the upper motor neurons is the location of the lesions. It's in the central nervous system. It's at the brain and spinal cord. For lower motor neuron, it starts from the anterior horn cell and to the peripheral nerve. So in this patient, it's more consistent with upper motor neurons, because from inspection there was no fasciculation seen, and his tone was pretty normal when I test the patients. It wasn't increase or decrease, but his power was reduced, the motor power reduced, and then the reflex was hyperreflexia in our case, and the plantar reflex was dorsiflexion, which is the Babinski positive, which makes this patient more consistent with the upper motor neuron. So combining with the pattern of motor weakness, which is paraplegia, which point out to the etiology of spinal cord and peripheral nerve, and when we see that the patient is more on upper motor neuron, so it is highly possible that the lesion is at the spinal cord. And to roughly state or find the level of the spinal cord lesions, we could group them to five group. For example, if the lesion is at C3 to C5 level, this is the most severe one, which the patient would be would not be able to move, like to move only. He would be able to move only his eye. He will be paralyzed from his arms to his leg. If it is at C6 to C8, he would still have some shoulder movement, but both of his hand and lower body would be paralyzed. And if it's T1 to T6, his upper extremity would be able to, he would still be able to move it with normal strength, but he will have complete paralysis in his lower half of the body. If it's T7 to T12, he would still be able to move his upper extremities, and he would still have like complete paralysis of lower bodies and legs. And if it's L1, it's the same thing. It's like just paralysis in his lower half of the body. So in this patient, we could say that the lesion is like at least like T1 and below. So it's probably not above like C8. And then we have to see which regions of the spinal cord is like affected. Usually based on the anatomy of the spinal cord, we could separate the spinal cord tract into two groups, into descending and ascending. In this case, I will be talking about ascending first. So as ascending tracts is mostly sensory, so sensations, and we have the three. We have dorsal column, which it's responsible for deep touch, proprioceptions, and vibratory. And we have lateral spinal thalamic tract, which is for pain and temperature, and we have like ventral spinal thalamic tract, which is for light touch. For descending tracts is more like motor. So we have lateral cortical spinal tracts, which is like the main voluntary motor for both. It's actually both for both like upper and lower motor neurons, and we have ventral cortical spinal tract as well. And to be more specific, as you can see, like each tract would have like each region of the tract would have like would affect different region of the area, right? So for example, like for the lateral cortical spinal tract, the more lateral, it's like the more in the lower half of the body. And as you move medially, it will move up to like thorax and cervical area. So in this patient, like we could say that like, okay, the patient have had weakness. So in his like lower body. So probably the lesion would be at the lateral cortical spinal tract, which is but still in the lateral area of the spinal cord. And he also reported the pinprick sensation deficit. So it could also affect his posterior column as well.
In this patient, if you imagine that we draw the lesion of the spinal cord, what do you think, which part would be involved? Like you mentioned the posterior and also the lateral and any other parts that from the information from the physical exam.
He had,
Yeah, lateral and
I think it's posterior and lateral and
both side or one side. Or,
side, because he had like both of his legs was affected.
so the lesion is quite in large area.
Yeah.
And also it's progress very, very fast. So you have to like not mention that it's growing mass or any complication from the mass, because like the patient mentioned that he had like a slow progressive of the weakness, and then also occasional numbness. And then in 2 days, the patient like cannot control his bowel or bladder, or cannot walk or cannot move. Okay.
So sorry. So when we talk about the lesions of the spinal cord, we could also separate them into like syndromes like transverse cord lesions or hemicord lesions. Sorry. So from this picture, we could see that there is like transverse cord which affect both half of the spinal cord, and we have hemicord lesion which only affect the one half of the spinal cord, and central cord lesion which affect the central part of the spinal cord, and central cord syndrome, which is like the large lesion of the central cord syndromes, and posterior cord syndrome, which affects only the posterior column, so only the sensations, and anterior cord syndrome, which usually it's caused by any like lesion in the anterior spinal artery, and will leave only like the posterior column intact. And in our patients, we suspect like probably like the transverse cord lesion, because he had like problem both sides, but while others is like only half of the body.
So this, I think this diagram is like show us many information, because in some the location or pattern of the lesion can tell you a lot of things, like can provide information to perform a differential diagnosis of the lesion in this case. Okay.
Okay, next, we could also then we will have to make a differential diagnosis. So we could do this based on like the onset and actually the pattern of the disease. In this case, the patient it's more like chronic and progressive, so we could cut out like other hyperacute or acute diseases like infarction and hemorrhage. So for the chronic progressive, it could be like neoplastic tumors or paraneoplastic, and even hereditary, and even the atypical types of like multiple sclerosis as well. And so this table will show like the differential diagnosis of each disease of each like of the disease based on the onset, and including the MRI like lesions. So in our case, we would like to focus on the chronic progressive, and so so the differential diagnosis of chronic progressive includes like tumor, sarcoidosis, atypical multiple sclerosis, and even metabolic and cancer as well. And because like the patient, because of the occasional weak decrease in sensation, so I will be talking about the relapsing fluctuating just a little bit. Like usually it would be like multiple sclerosis and even like neuromyelitis optica spectrum disorder. And so if we talk further about the characteristic of each differential diagnosis, and we would like to focus on in MS, multiple sclerosis, like in the MRI, we would see like the lesion would be in the posterior lateral part, probably in our case, but usually the patient will have like abnormal vision, like it will also affect the vision of the patients, but at this patient we don't have it.
MS and NMO is like relapsing, and the relapse can, like they say that it's different in time and in space. So sometimes it's like patient present with the ocular symptom. Sometimes patient present with the episode of weakness. So if you had a history of like previous history of eye disorder, and then it goes away, and then comes next with the episode of the neurological symptom, maybe the differential should be think of the MS on the type of MS and MO.
Another one is like the autoimmunes, like but usually autoimmune would have like systemic features as well. Another one is like paraneoplastic, which in MRI, if it's sagittal, it will be normal, but if in axial, you might see like some lesion in the central part of the gray matter. But usually the patient have to have like a diagnosis of any cancer or malignancy first.
I want to share a little bit about the paraneoplastic. During my medical residency, the patient present with like encephalitis and also the ataxia, and also all the cerebellar size positive. And then the patient later diagnosed with the breast cancer. So the paraneoplastic is the manifestation of the breast cancer in this patient. So after we approach that, the patient has pancerebellar syndrome, and then we have to find the etiology of pancerebellar, and then we find the cancer next. So the paraneoplastic is hard to diagnosis, and then we have to find the cancer. And also usually the prognosis in the patient with cancer and paraneoplastic usually like very low prognosis in the paraneoplastic syndrome.
Okay, thank you. Another one is the sarcoidosis, but usually sarcoidosis would have other involvement of like the lung, the eyes, of skin, and others. Another one that we like to focus on is like maybe probably like chronic infections, but usually we have other associated symptoms which the patient doesn't have. And lastly is the neoplastic, and in neoplastic, where is it primary or metastatic?
HIV and syphilis is also hard to diagnose in patient who present with the neurological symptom. Like syphilis can present like posterior cord syndrome, involve the dorsal column, and also HIV can manifest with like upper motor and lower motor, like HIV encephalitis, HIV with cord lesion, HIV with like peripheral neuropathy. So HIV itself can manifest in many syndrome of neurological disease.
Moreover, I think HIV may cause the opportunistic infections and present with the opportunistic such as fungal and also TB as well.
ขอบคุณค่ะพี่แอม like TB can present with like TB with cord involvement, TB encephalitis. So if the patient has HIV infection, the differential would be very broad in the opportunistic infection, as อาจารย์แอม has already mentioned.
Okay. So what are the differential diagnosis in this patient?
Differential should cover where is the lesion and what is the lesion. After you have like listened to the very concise mini lecture about the neurological examination, what do you think is where the lesion is and what is the etiology?
First one, I think, the most likely is a tumor in spinal cord that can involve lateral cortical spinal tract and maybe also dorsal column. In lateral cortical spinal tract, a patient presented with weakness below L2 level. Maybe it involved the lateral side of the lateral cortical spinal tract, and or maybe like Ajahn Kim said that firstly it have tumor and maybe it can have yes patient presented with a rapid progressive maybe tumor may be ruptured or maybe have a bleeding. I'm not sure. And it's patient presented with a increased deep tendon reflex at patella and Achilles. Mhm. If involved the reflex, I think it's involved or maybe all track of motor track below L2 level.
So where do you think the level of the lesion is?
I think the lesion will between T1 to T6 level because the patient can use both of his both of his arm and have normal motor grading in upper extremity, but lower extremity he already paralyzed it all of lower body and leg, and the trunk control of the patient is effect. So I think it between T1 to T6 level.
For the etiology, I think is due to chronic progressive weakness. The etiology maybe is vascular malformation or also tumor as well, or another is hereditary. This can consult can be.
So the differential diagnosis are like the spinal cord tumor because of the chronic progression and progressive weakness and weakness below the T4 level and including like any incontinences in his bowel and bladder and hyperreflexia. But the things that go against this is like usually spinal cord tumor would have like back pain and other constitutional symptoms like fever and weight loss, but the patient didn't have. Another one is like a transverse myelitis, even though like the progression is in this disease is mostly subacute progression, but the symptoms is pretty consistent, like the progressive weakness in both of his extremities, and pinprick sensation, loss below T4 level, and loss of bowel and bladder controls, and hyperreflexia. But the things that go against it is like the subacute progression of this disease and like no history of prior infection or back pain. Another one is like more atypical case of like multiple sclerosis, like because the patient had like weakness, loss of pinprick sensations, and even hyperreflexia. But the things that go against this is like usually the multiple sclerosis would come with like a relapsing and remitting course, and usually would affect the optic nerve. So the provisional diagnosis in this case is like spinal cord tumor with spinal compression at T4 level, because the sensation is lost like below the T4 level. So what is like the further investigation that you would like to do?
I think for the basic investigation, maybe plain film TL spy and another check a blood for CBC and kidney like liver function and anti-HIV anti-syphilis ค่ะ for the basic but maybe MRI spy for T level maybe should do in this patient ค่ะ
Okay, so in this patient, so according to this algorithm, so if the patient had like paraparesis in this case and with upper motor neuron sign without any cerebral sign, so the spinal MRI would be recommended. So, but in this case, firstly, plain film was done, and only like slight like scoliosis was noted, and the MRI was also done, and you would see this lesion here, this mass. In this is like the T5 level. You could see, and in the MRI thoracic spine with the contrast in T1 sagittal view, you could see like the hyperdense lesion here, the increased signal in this level, and you'd see that the spinal cord is compressed in between. And this is the axial view of the MRI. You could see the this dark structure here is the spinal cord. You can see that it is compressed by this hyperintensity lesion here. It's like a mass here. So it explained like so the official reading is like bone marrow infiltration, lesion at T5 vertical bodies, spinal process, and bilateral transverse process with an extension outside into the posterior epidural space, causing severe spinal stenosis pressure to spinal cord with myelopathy. So you can see that it said that it came the lesion come out from the bone to the posterior epidural space. So it goes to the posterior side of the spinal cord, and it also goes. It also affects the transverse process, so around the side of the lateral side of the spinal cord. So probably the lesion is something like this, where it compressed like the lateral spinal cord, cortical spinal tract, and the posterior column, which explain the disease, the symptoms of the patient. So the diagnosis was the epidural tumor with spinal cord compression at T5 level. So I would like to talk a little bit about the spinal cord tumor. Spinal cord tumor is it's not really a common tumor. It's like only 15% of the all CNS tumor, and the tumor could develop inside the spinal cord or around the spinal cord. And it could be either benign or malignant and separated into primary, secondary, which secondary is metastatic. And if it's primary, it's usually benign. If it's like secondary, it's usually malignant from like it's metastatic from prostate cancer, breast cancer, and lung cancer. And the classification of spinal cord tumor could be classified based on location. So it could be extradural, so outside the spinal cord, and from intradural, extramedullary, and intramedullary, so inside the spinal cord. So this is like the pictures in each classification. So the first one that I would like to talk about is the extradural, which is the most common and usually caused by metastasis. And it arises from the outside of the spinal cord and compress the spine, and usually in the epidural area, and it could also be from outside the dura as well. Mostly from prostate cancer, breast cancer, and lung cancer. The second most common is intradural extramedullary. So it's not exactly inside the spinal cord, but it grows like in the dura mater. And there are usually two common types, which is meningiomas and schwannomas. For meningiomas, it's usually in women and of age of 50, 60, and the location is most commonly in the thoracic spine. For a schwannoma, it's in slightly younger patients in 40, 50 years old, and usually from the dorsal nerve root, and it is also associated with NF2, type 2. And the intramedullary which is mostly primary tumor and benign. And two most common types include ependymomas and astrocytoma. And for ependymomas, usually occurs in the lumbar or sacral part, and usually in the age of 30, 40 years old, and usually start in the central area of the spinal cord. And for astrocytoma, usually in thoracic region, and it's the most common spinal tumor in children. So signs and symptoms of of most of the spinal cord tumors are back pain, which usually will come before like other neurological symptoms. And back pain's one characteristic is that it's like night awakening because of the pain. And the pain could be radicular or localized as well. And for the neurological symptoms, it's based on like which tract it compress or cause lesions. Like it could cause muscle weakness, paresthesia, bowel and bladder dysfunctions, and weakness that cause into like difficult ambulations. But usually the symptoms are progressive, and other are like unexplained weight loss. So investigation of choice is MRI with contrast of a spine, and also should include the whole spine, because as you know that like for the metastatic tumor, it could also affect other levels of the spinal cord. And for second line options, it's like the CT myelography. So this is like the picture of an MRI in the intramedullary. So as you can see that the tumor is inside, it's exactly inside the spinal cord. For the intradural or extramedullary is in the dura mater, and the extradural is like, as you can see, it starts from the spinous process, and then it compresses the spinal cord. Okay, so treatment is actually based on the pathology of the disease, but generally, if you separated them into a classification, if it's like intradural extramedullary tumors, usually complete surgical resection would be done, and radiation would be done if it's malignant. If it's intramedullary tumors, if possible, complete tumor resection is usually recommended, and radiation as supplement. For extradural, because it's mostly metastatic, so the complete resection is not really recommended, but usually we will start with like giving steroids to help relieve any neurological symptoms, and chemotherapy and radiation to further control the symptoms. Okay. So the management in this patient is so the consultation to orthopedist was made, and so the orthopedist did like MRI, and then because since the patient and then the patient was referred to another hospital for surgical decompression and tissue biopsy. So we don't really know the exact diagnosis. I mean the pathology of this disease. So others are just are like additional information like possible complication in spinal tumor apart from like the symptoms, like if the neurological impairment could lead to loss of daily functions, pressure ulcer, UTI, deep vein thrombosis, stress and anxiety, and depression. And if the patient is bedridden, could also pose like a problem to the caregiver as well. And the holistic approach in this patient, we should do a comprehensive assessment. So apart from any medical history and physical examination or even diagnosis that we make, we should assess like psychological and emotional status, like whether he had depression after receiving this bad news or any social assessment, any supporting system, and including also spiritual assessment. And we should also focus on patient-centered care. So we would provide all the information like the diagnosis and the way of treatment, and let the patient decide which one is the best for himself. And this will also include multidisciplinary teams like orthopedic, rehabilitations, even family medicine as well. So these are the reference in these slides, and thank you for your attention. Do you have any question? อาจารย์แอมมีอะไรอยากเสริมไหมครับผม
ค่ะก็น้องทำสไลด์ได้ดีนะคะก็คือครบถ้วนเนาะตั้งแต่ไล่ประวัติมาแล้วก็ตรวจร่างกายการ differential diagnosis นะคะรวมถึงการ management เนาะแล้วก็สำเนียงภาษาอังกฤษดีมากเลยค่ะก็ดีนะคะก็ขอให้รักษาความดีต่อไปนะคะอาจจะเพิ่มเติมนิดนึงก็คือในเรื่องของการ advice ผู้ป่วยอะนะคะกรณีคนไข้อะถ้าไม่ว่าจะมาด้วยก้อนที่ไหนก็ตามหรือเป็นกลุ่ม tumor อะไรก็ตามเนี่ยสิ่งที่คนไข้มักจะอยากได้ยินคือ1 tumor เนี่ยเป็นมะเร็งหรือเปล่านะคะหรือว่าเป็นแค่เนื้องอกปกติอันที่2คือส่งต่อไปยังบุคคลอื่นในครอบครัวได้หรือเปล่าอะไรเงี้ยค่ะก็จะอันที่3คือรักษาหายหรือเปล่าหรือว่ามีโอกาสเป็นซ้ำเท่าไหร่พี่ว่านี้เป็นคำถามบ่อยๆที่คนไข้มักจะถามในกรณีที่มีก้อนนะคะก็อาจจะฝากไว้เท่านี้ค่ะแต่ว่าโดยรวมก็ดีมากค่ะ
ครับขอบคุณครับอาจารย์ เพื่อนๆมีคำถามอะไรไหมฮะ ก็ถ้าไม่มีแล้วเดี๋ยวขออนุญาตปิดคอนเฟอเรนซ์ครับผม ขอบคุณครับอาจารย์